for your interest. We're just delighted at the level of interest that's been shown in this webinar. We'll just give a few minutes for everyone to join, a few seconds rather. Good afternoon, good morning, good afternoon, good evening. So I think we can begin now. Thank you once again for your participation. Really, it's very heartwarming to see the level of interest in this topic. We have two very eminent speakers today. Dr. Sylvie Briand, who's the director of the Department of Epidemic and Pandemic Preparedness and Prevention at WHO headquarters, will be giving the opening remarks. Sylvie is very experienced leader, having led for many pandemics and epidemics. She's also known for her innovative approach, and it was under her leadership that the WHO Information Network for Epidemics, or EPI-WIN, under which we are holding this webinar, was started at the beginning of COVID-19. So we're very fortunate to have her with us. And following Sylvie, we have Dr. Rosamund Lewis, who's a foremost expert on monkeypox and a technical officer at WHO headquarters. She'll give the technical briefing, which will provide you with hopefully all the information that you're looking for. And after her presentation, we will have questions and answers. Before I hand over the floor, a few housekeeping points. This webinar is being recorded, and it's also being streamed live on YouTube, so you can also join us through YouTube. If you have any questions, and I'm sure you will, please put your questions down on the Q&A, not on the chat, because there's a possibility it might be missed in the chat. So please put your questions on the Q&A. We'll try our best to answer as many as we can within this hour. And without any further ado, then I hand over the floor to Dr. Sylvie Briand. Once again, welcome.
Thank you very much, Supriya, and welcome to everyone. Good morning, good afternoon, or good evening, depending where you are in the world. And I would like to thank you to join us for this EPI-WIN webinar on monkeypox. This is the first EPI-WIN webinar that we are organizing on a non-COVID-19 topic. And we would like to highlight by organizing this webinar that even if we use the same channel, EPI-WIN, monkeypox is very different from COVID-19. First, because it's a disease that is known already. We have had it in endemic countries, but before it was contained in those countries, but now we have seen since a few weeks now, beginning of May actually, that the disease has spread to other countries. We have currently 23 countries reporting cases. We are above 250 cases confirmed already, and the situation is evolving and changing very rapidly. So that's why we would like really to have this discussion with you all so that you can ask questions to the experts and make sure that you have the right information at the right time in the right format. So WHO will use many different channels to provide this information. One of these channels is our open WHO platform, where you can find a number of courses that have been developed by the team here, in particular under the leadership of Rosamund Lewis. You will hear her later after that. So for us, what is really important when we do those seminars and webinars, it's really because we want to share knowledge. So we don't have all the knowledge currently. The science is working very fast currently to get more insight on the unknowns, because there are still many unknowns on this disease. But as we know more, we will try to share it with you, and so that we can advance together on this path of knowledge. regarding the current situation, we think it's important for as many people as possible to understand what is the current situation. First, it's an unusual situation, as I said, because before we had this disease only in certain countries, and now it's, I would say, out of the box, and we have cases of this disease confirmed in many countries in the world. But we still think that these are this is a small number of cases, and we still think that this outbreak is containable. And so we have issued guidance for health authorities, for the public, for different communities to make sure that people know what to do to control the spread of this disease. And awareness is absolutely key for that, because if you are not aware that there is a problem, then you cannot do anything to control it. So that's why we also want everybody who can make a difference to have access to the information in time, so that they can really protect themselves, but also protect the community in which they are living, and give the professionals also all the information they need to do better their job. The risk for general public is low, so we don't want people to panic or to be afraid and maybe think that it's like COVID but worse. No, it's different, and we do have the tools and the right recommendation to really empower everybody to manage the situation. So please just try to avoid close physical contact with people with symptoms, and this will protect you for the time being. And we are developing also other approaches and interventions so that we can even increase this level of protection. So even if this risk is low, we really want countries and health authorities to know that this unusual situation is developing, because we think that there are key things that can be put in place now, and that will make a difference for the future weeks. And we all want to go back to the new normal after 2.5 years of COVID. Nobody wants lockdown or isolation of a patient and so on anymore. So that's why let's try to work together to mitigate this as much as possible, and just make sure that we control this new outbreak as efficiently as possible. So Rosamund will give you a lot more data on this, but again, I re-emphasize that it's this monkeypox disease is not COVID-19. It's a different virus. It's a different disease. And so that's why we need all to learn a little bit more about this new disease. With no further ado, I will give the floor to Rosamund Lewis. I just would like to say that I really appreciate all the work Rosamund has done in the past years, because she was in charge of a disease, smallpox, a disease which has been eradicated in 1978. And so we still have, we're watching this disease very carefully, because we were afraid that it could re-emerge. And Rosamund, when she saw that the monkeypox disease was creating more and more outbreaks in endemic countries, decided to drive a preparedness agenda for monkeypox. So this preparedness agenda now will be very useful nowadays, because now we have some tools in place and some mechanism in place that will enable us at global level to manage this outbreak much better than if we had just discovered it today. So I give you the floor, Rosamund, to explain us what is this monkeypox outbreak and what are the risks for all of us. Thank you very much.
Thank you very much, Sylvie. Now we go over to Rosamund for the technical briefing. Over to you, Rosamund.
Thank you very much, Supriya and Sylvie, for the very kind introduction. We will begin with a slide set, which has been prepared by and with the EPI-WIN team. And so my challenge here is to share with you let me know when you can see the slide, Supriya, please.
We can see the slide, but if you could put it on, yes, thank you.
Is that working? well, we can get started. So this EPI-WIN slide set, which has become a legendary set of slides that the EPI-WIN team puts out on a regular basis. So we will just go through this and then we will take questions, of course. Many of you have already provided questions in advance, so those are very helpful. So what do we already know about monkeypox? Monkeypox is a zoonotic disease. So of course that means the virus itself circulates in certain animal groups and then can spill over into the human population. Most of the new cases of monkeypox, however, are now being reported in non-endemic countries. Since May 2022, so since the 14th of May, several non-endemic countries in 4 WHO regions have reported monkeypox. In the past 5 years, we've had 9 cases of exported monkeypox reported. In the United Kingdom, in Israel, 1, in Singapore, 1, and in the United Kingdom, several, and in the United States, 2 cases. So these were just indicators that virus was hitching a ride with travelers and arriving in countries where it wouldn't normally occur. However, most of the cases now that we have do not have any link to travel, from endemic countries. These countries are the Central and West Africa. So what we're seeing right now is a very unusual situation. It's atypical. We don't normally see dozens, scores, or hundreds of cases appearing in many countries at the same time. So this is what we're actually seeing today. What you don't have highlighted on this particular map is the endemic countries, which are Central Africa, Congo Basin area, so Democratic Republic of the Congo, Central African Republic, and Cameroon, and then West Africa, Nigeria, and a few countries there. The 4 countries that have been having outbreaks in the last few years are Nigeria, Cameroon, Central African Republic, and the Democratic Republic of the Congo. What you see on this map now is the early number of cases that were reported starting in Europe. In the UK, the first clusters were in the United Kingdom, followed by Portugal and Spain, Sweden, and then soon we started seeing cases in the United States, Canada, Australia, and we now also have cases in the Paho region in South America, as well as in parts of the Eastern Mediterranean region. These are appearing in some cases as single cases. In some cases, they're appearing as clusters. So let's go back to say, what is the virus that's causing this condition? Monkeypox is caused by something called the monkeypox virus. It is related to the virus that used to call smallpox. As Sylvie said, this was eradicated over 40 years ago. So the monkeypox virus is part of the orthopox virus genus, which includes variola virus, which used to cause smallpox, and cowpox, and there are a number of others. There are 2 main strains of the monkeypox virus, which are the Congo Basin clade. So those are the Central African countries that I described just now. And then the other clade is the West African clade. The West African clade has historically been less virulent, and it is the one that is currently being identified in cases in different countries across the world. Having a virus that causes less severe disease is a good thing, obviously, but it also has the other side of it, that because the disease is less severe, people can move and travel with their infection and may not need to feel that they need to stay at home. The reservoir of this particular virus is unknown. We have a number of primarily rodents, which are suspected to play a part in the endemic setting. So why is this thing even called monkeypox then? So it's called monkeypox because it was very first identified in 1958 in sooty Mangabe monkeys in research colonies in Copenhagen in Denmark. So in 1958 was the first time this virus was identified, and the first host in which it was identified was a monkey. Hence, it was named monkeypox in contrast to smallpox, which at the time was still prevalent in many countries of the world. So now we have a situation where, in fact, most of the hosts of this disease are in fact rodents. So squirrels, pouched rats, Gambian pouched rats, and different types of rodents that are common in the Central and West African setting have been the hosts that have been the zoonotic hosts of this virus, causing small outbreaks in forested regions. And today, we're seeing a different situation. But this is the origin of the term and the natural history of the virus. So when we are actually seeing monkeypox as an infectious disease, what are we actually looking at? It has historically usually been a self-limited disease. That is still the case today, and typically lasts 2 to 4 weeks. We will learn about the cases we are seeing now. But so far, this information that we have from 40 years of monitoring monkeypox still holds. It can be more severe in some people, and this includes our usual vulnerable groups. It can be much more severe in young children, in pregnant women, or persons with immune suppression due to other health conditions. There have been some suggestion that untreated HIV may be a risk factor for more severe disease, for example, in the African setting. If a person has a properly treated and controlled HIV infection, there's no reason that they would be more susceptible than anybody else. The incubation period is a subject of debate. So we'll say right now, we don't fully know what the incubation period truly is, because this is something that has been emerging over time. Studies have been limited. Investment in research in Africa has been limited, which is something that may change now, one can hope. But basically, the limited studies that we have suggest that the incubation period ranges between 6 and 13 days, although we have seen some extremes from 5 days to 17 days and above. And for public health purposes, in terms of managing cases, this is the information that we currently have. And the more we learn about this disease, the better we'll be able to pinpoint incubation periods, infectious periods, and all those things that are really important in managing an infectious disease. Typical symptoms at the beginning of the illness is usually preceded by a 1 to 2 day prodromal phase with many viral conditions that you're already familiar with. This is similar. So fever, headache, muscle aches, backache, lack of energy, swollen lymph nodes, and a typical skin rash or lesions. The swollen lymph nodes are quite typical for monkeypox. And this is important because at the time that it was first discovered, this was a distinguishing feature that separated smallpox from monkeypox. During the smallpox eradication era, it was really important to find every single last case of smallpox in order to confirm eradication. And monkeypox was only just being discovered, as we mentioned, in 1958, but in 1970 was the first time that there was monkeypox discovered in a human, and that was a 9-month-old child. So we had this overlap between smallpox and monkeypox of really just a few years. And so during that overlap period, there was a lot of information given to communities about what does smallpox look like? What does monkeypox look like? Clinically, they can be quite similar. One difference is that smallpox was much more severe. Monkeypox is less severe. Smallpox was more infectious. Monkeypox was less infectious. Smallpox did not really classically have swollen lymph nodes. Monkeypox had classical swollen lymph nodes. So this was an important distinguishing feature at the time. The skin rash or lesions are really quite typical. Now we're talking about the classic presentation as we have seen in the past, and we'll come to any differences that we may be seeing in the current presentation worldwide at the moment. The classic presentation that we've seen in the past is that the rash first appears on the head or neck. It then progresses in what's called a centrifugal pattern. It leaves the center and it goes to the limbs. So hands, limbs, arms, legs, but also hands, palms of the hands and soles of the feet, which can occur in other infectious diseases, but is quite classic for monkeypox. And these lesions then progress to the trunk. Lesions in the genital area are not something new. Those have been there for a while. I mean, they've always been classically described. And as the lesions progress across the trunk, then we see that some people can have a full body rash. The lesions themselves also progress in a very classic manner. They go from something that are called macules. Macules is just like a little red patch on the skin. Then papules. Papules is something clinically that you can feel is raised and slightly firm or indurated. Then they become vesicles, which is like a little blister. with fluid inside. And this is where confusion with chickenpox can come in. Chickenpox is not from the same family of viruses, but it can cause blister-like rash. So having this chickenpox concern, be able to distinguish between chickenpox and monkeypox is important, and has been particularly important in African settings where vaccines for these two diseases are not yet available. So once the vesicles are formed, they can also then begin to fill with a whitish fluid, and they become known as pustules. Those pustules will eventually dry. They form crusts, and those crusts will fall off. They'll dry up and fall off, and fresh skin will form underneath. That whole cycle can easily take 2 to 4 weeks. So this is really important as a feature when it comes to managing monkeypox, because of how long someone can actually remain infectious once they have the condition. We've already talked about the classic swelling of lymph nodes, and we've talked about the eruption begins after first couple of days of a prodromal period. And we've talked about the way the lesions form, present, and evolve over time. All the lesions are usually at the same stage of evolution as they progress on the body. The case fatality ratio is an important number that you're all familiar with now. So again, this varies because we have 2 clades in the African setting. The Congo Basin clade has traditionally been said to be more severe and may cause death in up to 1 in 10 cases. And in the West African clade, the case fatality ratio, which is the number of deaths over the reported number of cases, has been reported to be around 1% or less. So there's a difference between 1 in 100 and 1 in 10. These already sound like high numbers and important numbers, but there are a number of things that we need to take into consideration. So first of all, over time, as you know, the world stopped vaccinating against smallpox 40 years ago. So whereas the classic descriptions of outbreaks of monkeypox occurred a number of years ago already, the population that was experiencing those were much younger. They were children. They were children who had not been vaccinated because vaccination stopped in the 1980s. In that time, in those 40 years, of course, the population susceptible to pox viruses, including monkeypox, has on average gotten older. So now the mean age of cases is really more commonly around the early 20s, for example. Young adults are typical cases for monkeypox. So the proportion of people who are young children and at higher risk is lower. So that's one reason why the case fatality ratio may be lower today. The second reason why the case fatality ratio may be lower today is that the cases we are seeing, again, in this multi-country outbreak are so far mostly in young adults, and again, with robust immune systems. And so we expect that the case fatality ratio will be lower in this current multi-country outbreak. There have not been any deaths reported so far, and we hope to keep it that way. So how does this actually transmit? This is a really important question, because this is how we manage infectious diseases and how we can respond to infectious diseases and try to control the spread. So as we've already mentioned, a person with monkeypox remains infectious as long as they have symptoms, and also as long as their lesions have not crusted over and fallen off. This can take some time. The presentation of current cases that we're seeing now tends to be similar as the cases described in the past, but there's a higher proportion of people who may have fewer lesions and concentrated more in the nether regions of the body, the perineal region, genital region, and even perianal region. So we'll come back to that in a minute. But monkeypox is, so sometimes these lesions may not even be visible, is what we're saying here, that you may have these lesions for 2 to 4 weeks. They may not all be visible to others, but you may still be the person who has it may still be infectious. So monkeypox virus is transmitted classically, and as far as we know, also in the current situation, from one person to another by close physical contact with lesions, body fluids, or contaminating materials, including bedding or clothing, for example. So there have been cases where monkeypox has been acquired through managing bed linen in the hospital. So now efforts to support and protect health workers are also front and center of what WHO is doing. Another feature that I didn't mention earlier is that ulcers and lesions can also appear in the mouth. So you have the lesions on the skin, but you also have the lesions also known as enanthem in medical language. So you have the enanthem in the mouth, which can be little ulcers, little sores, and those can, of course, would also be have a lot of virus in them. And so that from just contact with the mouth, contact with saliva may be a means of spreading this virus. So people who closely interact with someone who is infectious, including health workers, household members, and sexual partners, are at greater risk of infection. Transmission can occur via the placenta from mother to fetus, which can lead to congenital monkeypox. This has been described, or loss of the pregnancy, unfortunately, and also during close contact during and after birth. What we're seeing in the present multi-country outbreak, and basically in epidemiology, when we initiate an outbreak investigation, what we do is we describe what we see, right? We don't postulate right away, we don't hypothesize. The very first thing we do is describe what we see. So what we are seeing in this current outbreak is that the vast majority of cases and cases that are appearing around the world in different countries are in men who have sex with men. It's very important to describe this because it appears to be an increase in a mode of transmission that it may have been under-recognized in the past. And of course, having sexual activity with someone brings you in very close physical contact. So it is not yet known whether this is a traditional, quote, sexually transmitted infection. It is not yet known whether this virus is exploiting a new mode of transmission, but certainly what is clear is that it continues to exploit its well-known mode of transmission, which is close physical contact. As mentioned, we also talked about droplets from the mouth, respiratory droplets. It has been described as a respiratory infection. This was also an analogy to smallpox, which was clearly a respiratory infection. Monkeypox had always been less present fewer respiratory manifestations. There are some very rare conditions such as encephalitis and bronchopneumonia. They have been described, but they are very unusual. And so there has fewer respiratory manifestations in monkeypox than there have been in smallpox in the past. However, there's a lot we still don't know. So classically described as a respiratory disease with transmission through droplets, we actually don't have the information right now as to whether there may also be a form of aerosol transmission. These are all things that need to be explored and discovered even as we manage this outbreak at the present time. So having said that, then what are the appropriate protective measures that we can already engage in now? So one is to obviously protect yourself and others. And we at WHO is working with partners around the world right now on developing risk communication messages for the appropriate audiences such as yourselves and other selected target groups and countries where cases are appearing. The important messages are to avoid close contact with people who do have suspected or confirmed monkeypox. It's clear that you may contract it from touching lesions in the mouth with any part of your body. And so avoiding that close physical contact is really important. When you're caring for, if you're a health worker or even someone at home and you're caring for someone who may have monkeypox or has confirmed case of monkeypox, you really have to encourage the person to cover the lesions with light bandage, with a sheet, with clothing, so that the shedding from the lesions, the shedding of virus from the lesions is minimized. The person should wear a medical mask, and the person caring for the person should also wear a medical mask. Avoid skin-to-skin contact and use disposable gloves. Then the usual messages that we have been providing around hand hygiene: clean your hands regularly with soap and water or alcohol-based hand rub, especially after contact with the patient or contaminated materials. And take a great amount of care when managing a laundry, linen, clothes, towels, bed sheets, and utensils, and wash them as one normally would, but making sure that they are put in a separate location, kept away from your face while managing these things. So, goggles, eye protection, masks are appropriate for managing environmental waste or materials that could be contaminated. And of course, clean and disinfect any contaminated surfaces and dispose of the waste. So what is WHO doing already now with countries, of course, and partners to manage the spread of monkeypox in this unusual situation? early detection, isolation, and treatment of persons with monkeypox is critical. We do have collectively, the world has an opportunity to stop this outbreak. It is definitely, there's a window of opportunity where this can be contained. There are still, when you count the number of cases, there are still relatively few cases per location, per country, per city, per health facility. And so any one case should be manageable through contact tracing and isolation. So any person with suspected or confirmed monkeypox should be isolated until their lesions have crusted and the scabs have fallen off. As soon as a suspected case is identified, contact tracing should be initiated. Contact should be monitored daily for the onset of symptoms for a period of 21 days. This is the maximum incubation period. So if you're in contact with someone and you're monitoring your symptoms, you need to do that for 21 days. That means, of course, monitoring fever, monitoring other symptoms such as headache or backache, monitoring the appearance of lymph nodes or lesions and skin rashes of some kind. This can be done individually, but under the supervision of your local public health unit or healthcare provider, and local public health units should be also actively monitoring contacts if they have the time, the ability, and the resources. Asymptomatic contacts, so persons who are contacts but have not developed symptoms of any kind, should nonetheless not donate blood, cells, tissue, organs, breast milk, or semen while they're under symptom monitoring. Contacts without symptoms can continue daily activities. You may see some differences of messaging around this particular point. Until now, what has been recognized is that definitely the infectious period is from when the time the rash appears until the scabs fall off. The prodromal period may be also an infectious period, but there's very little information and it's not really fully understood. And whether there's any transmission in people without symptoms, there's also very limited information on this. There was some information published on studies done between 1981 and 1986 in the Democratic Republic of the Congo, which showed that unvaccinated contacts, because at the time smallpox vaccine was being used for smallpox, but unvaccinated contacts of a monkeypox case may have had contact, obviously, with the family member or the neighbor, and there was about 3.5% were found to have antibodies. This may have been through contact, but it also may have been through low-level exposure to the zoonotic virus in the environment where they were living. So we really don't actually yet know whether there's asymptomatic transmission of monkeypox. The indications in the past have been that this is not a major feature, but this remains to be determined. So at the moment, trying to balance risks, benefits, potential unintended harms. At the moment, the guidance is that contacts without symptoms can continue about their daily business, but must be very closely monitored by their public health unit and also participate actively in self-monitoring so that any symptoms that do arise can be detected very early and in a very timely manner. Health workers should have personal protective equipment, as mentioned earlier, and any health workers who have unprotected exposures that they're not having the appropriate PPE to patients with monkeypox do not need to be excluded from work if asymptomatic either, but should also participate in the active ongoing monitoring of symptoms. WHO has already put out guidance, interim guidance on 2 areas. One is on case detection, contact tracing, and investigation. That is on the WHO website. On the WHO monkeypox health topic page, you go to the main page of the website, you look for health topics, you go to M and you type monkeypox, and that's where you'll find WHO is now putting materials. You can also access it through the main WHO webpage, scroll down a bit, and you'll find the monkeypox information links there. The second, so I've mentioned the information on contact tracing, surveillance and contact tracing. And the second guidance that is already out is on how, for laboratory officers and personnel, how to diagnose a monkeypox infection through laboratory confirmation. The primary test that is being recommended right now, which is usually available at national level, is PCR. Capacity may be expanding rapidly on who can do a PCR for monkeypox. There are monkeypox-specific PCR tests, and the best diagnostic sample for that is actually the skin lesion, whether it be fluid from the vesicle, fluid from the pustule, crust from the lesion itself. Those all contain virus, and that's why that's such a contagious thing when it comes to direct face-to-face contact or person-to-person contact. But these specimens are the best ones for sending for PCR. There is a lot of work ongoing already, as you can imagine, on collecting information from partners around the world on the work that was being done already and is now being done anew on rapid diagnostic testing. In terms of clinical care, I think this flows very much from what we've already discussed. Care should focus on alleviating the symptoms that we've talked about, managing any complications that arise, and preventing long-term consequences of monkeypox. Because you can have lesions on the skin, on the hands, it's also possible to get them in the eyes. Very important not to touch your own eyes and to wash any skin lesions with soap and water or special solutions to keep your skin as clean as possible. It's best to leave them to air dry, but if they are weepy or irritated or painful or itchy, they can also be covered with a light dressing. And any secondary bacterial infections should also be treated with topical or oral antibiotics as determined by the clinician taking care of the patient. So we've talked about the skin care, we've talked about eye care in locations where nutritional status of children may be an issue. Vitamin A supplementation is well known to help preserve sight, and so it may also be helpful here. For mouth care, we've talked about lesions in the mouth. Again, keeping the mouth clean with home remedies such as warm, clean, salted water or other products and oral analgesic medication to minimize pain so that people can continue to drink fluids, eat, and maintain their nutrition. There is one specific treatment, antiviral agent, which has been approved for treatment of monkeypox. It was developed for treatment of smallpox, but there is proof of concept in animal studies and a few human compassionate use cases that tecovirimat is effective as well against other orthopox viruses, including monkeypox. And so this treatment has been approved by the European Medicines Agency. However, as many of these products, as with vaccines, you'll hear in a minute, these products are new and not widely available yet. So WHO is working on that. So the same story here is that vaccines have been the subject of, as Dr. Briand mentioned to you at the very beginning, have been the subject of many years of research for preparedness in the event of a smallpox reemergence, which could have happened through a natural, accidental, or even a deliberate event. And so the world did have a measure of preparedness against smallpox. And so many of these products are now being looked at if they're helpful for monkeypox. So in the past, vaccination against smallpox was demonstrated to be about 85% effective in preventing monkeypox. These are old studies that I've already mentioned from the 70s and 80s. And at the present, there is just one new vaccine, smallpox vaccine, which has in fact already been approved, not only for smallpox, but also for monkeypox. It's known as EPI-WIN. It's a specific strain of vaccinia. All smallpox vaccines are in fact vaccines that are this orthopox virus that causes an immune reaction, which generates an immune response, which protects against smallpox and monkeypox. So this is vaccinia based vaccines, and MVA's modified vaccinia Ankara strain produced by Bavarian Nordic. And this is the only product that has to date been approved for the prevention and post-exposure prophylaxis of contacts for monkeypox. The availability of this product, which is relatively new, is also extremely limited. But some countries do have access to some of these products that they were beginning to procure before this event occurred. And WHO, as well as member states, are putting out guidance on the use of vaccines. And WHO is also initiating work to coordinate global response and access to vaccine products and the therapeutics I mentioned earlier. So these are some of the things that we've already talked about. We've talked about WHO working and partners working with member states to understand the source and the characteristics of this current outbreak and raise awareness of monkeypox symptoms and possible protective measures. Guidance is already being developed on surveillance, case definitions, contact tracing, and isolation, and new guidance for laboratory testing is available. The links, you will have them in the slides when you receive them. Public health investigations are ongoing in all countries where cases are appearing, and other countries are preparing for the appearance of cases. Genomic sequence is already being undertaken. We've seen a handful of genomic sequences being posted online. And so there's now debate and discussion beginning as to whether this virus has evolved or is evolving. And vaccination, as I mentioned, is already being deployed in some countries to manage close contacts and to prevent infection in possibly exposed health workers. In all of these areas of work, WHO is convening their expert groups to provide guidance and advice to the Secretariat, which in turn develops the recommendations to provide guidance and advice to member states and health authorities around the world. You will have a series of resources available to you. And so there are trainings online already. There's an introductory training on OpenWHO. It is available already in English and French, and some translations are underway. There is also an extended, so the first introductory training takes about 20 minutes, then it's a slide set that just rolls, you can just watch it. The second training, an extended training, is about 4 separate modules. It takes 2.5 to 3 hours to do the whole training if you sit and really do it. But again, you can watch as the slide sets roll with animations and voiceover, so that it's relatively simple to engage with the training itself. The extended training is also available in English and in French. We already have a monkeypox outbreaks toolbox that has been online for some time, 2 or 3 years, and this is being updated in real time as new materials become available and they are posted online. From our main webpage, we have key facts about monkeypox. So Q&A, we have the main website where you'll begin to find these various products and guidance materials. And we also have a specific information sheet for men who have sex with men, because at the moment, as described at the very beginning, this group of people are those who are most affected by the cases at the present time. And the idea is to obviously stop further spread so that it doesn't affect the more general population. Having said that, anyone can be at risk. General risk for the general public is considered low at the present time, but it would be unfortunate if this orthopox virus is allowed to exploit a new mode of transmission and establish itself as a human-to-human, an infection capable of human-to-human transmission, and exploit the immunity gap left by smallpox 40 years ago. So WHO is very keen upon the history of smallpox eradication to also stop this outbreak as soon as possible. Thanks very much.
Thank you so much, Rose. Thank you, Rosamond, for that very comprehensive and very, very clear presentation. I think that although we have a number of questions, I think your presentation actually answered many of the questions that people were asking. But before I go on to Q&A, I'd like to invite Sylvie Briand as well, get the floor to her.
Yes, thanks a lot, Supriya. I just want to apologize for the people because I know we have seen that many people couldn't join because I don't know why the Zoom platform put a threshold that was not supposed to be there. So we apologize for all the people who couldn't join. But the event is streamlined on YouTube, and there have been the link was put on in the chat. So if some of your friends wants to join, please share with them the link. And we apologize for this, and we will maybe organize another event very soon with an update so that the people who couldn't join today can have access also to this information. Regarding the slide set, it will be, of course, shared with the participant, but also we will put it on our website. We have an EPI-WIN page on which you can find all the EPI-WIN slide sets. And so you will also be given the link to those slide sets. Then I just want to highlight, and Dr. Lewis was very clear on that, there are still many unknowns. So you have to accept also that science, even if science is moving fast, we cannot know everything in a few days. It takes some time to conduct the research and so on. So regarding the transmission, it was clearly highlighted that there is respiratory transmission. And so we are still investigating if this transmission is mostly through droplets or could be airborne through aerosols as well. So we will have this week on the 1st and 2nd of June, on the 2nd and 3rd of June, a global meeting for the research community, where we will also highlight the key questions we have on this disease, and we'll have group of researchers around the world investigating this, and we hope to be able to give you much more details on the mode of transmission very soon. But we all have to be patient. There are some this is part of the infectious disease reality. There are always different modes of transmission. It's always very hard to understand what are the predominant mode of transmission depending on the context. So please bear with us with this. We are working on it. And as soon as we have more information, we will share it with you all, absolutely. What is clear as well, and I think it was alluded to in the last slide, and this is why we posted some specific recommendation, is that when we have a mass gathering, the opportunity for close contact is much more important. So we are also working with our team specialized in mass gathering to issue recommendations for mass gathering. We know that summer is often the case, is often the opportunity to have a lot of cultural festivals and parties and so on. So we will provide also guidance on how to have safe gathering. So this was my main point, and now I give you the floor, Supriya, for the question and answer session. Thank you very much.
Thank you very much, Sylvie, for those remarks and for clarifying a number of points, especially regarding transmission and others. So we have a number of questions. I'll start, Rosamund, with some questions that we received earlier today, even before the two questions. One is there an estimation of the basic reproduction number for monkeypox? Although it depends, what is it for this outbreak? And the second from the same person is, does recovery from infection or disease confer long-lasting immunity?
Thank you very much. Yes, so the R0 has always in the past been described as being just under 1, which means that in its natural habitat, with zoonotic spillover events, where somebody would acquire the virus from hunting or catching or preparing or consuming insufficiently cooked bushmeat, for example, which is a traditional practice, then there would be a case and maybe a second or third case. Chains of transmission have been short, 6, maybe a maximum of 9 recently reported. So in the past, R0 has been less than 1. But as you know, the transmission rate is a function not only of the virus itself, but of the control measures that are then put in place. And now in this current outbreak, we don't yet have an estimation of R0, but regardless of that, it's clear that if there is frequent physical contact and multiple contacts in a short period of time, that we can experience amplifying events. We believe that perhaps this is what has triggered that there may have been some undetected transmission already occurring. We saw, as I mentioned, 9 cases confirmed to be imported through travel in the last 5 years, but clearly there would have been more that were undetected. So somehow this virus found a niche where there's frequent physical contact, and so the amplifying events that may have led to this outbreak remain to be fully investigated and described. We don't have much information on that at the moment. So what's critical about this is whether the R0 is less than or greater than 1. If it's greater than 1 at the moment, the most critical thing is control measures, is putting barriers, as it were, between the virus and the next person that it could infect. And so hence the emphasis, as Sylvia has said, at the beginning of an infectious disease outbreak investigation, describing what you see and immediately responding to what we already know, even while acknowledging there's many things we don't know. So what we already know is that physical contact, close contact, face-to-face contact, skin-to-skin contact. These are all modes of transmission which can lead to rapid spread if they are not stopped. So we are, in fact, strongly encouraging outreach to communities that are more affected at the moment. That includes men who have sex with men, people who may self-identify as gay or bisexual, need to have this information so they can protect themselves and manage their own risk. With respect to recovery from infection, this is again one of those areas where we don't have a lot of information. Smallpox itself and smallpox vaccine generally tended to confer lifelong, certainly smallpox conferred lifelong immunity, and most smallpox vaccinations also conferred extended, if not lifelong immunity. Again, we don't know about this because it's been 40, 50 years since most of us have received our smallpox vaccine. As to whether those of us who are over 50 are still protected, that's an open question. However, in the African setting, we have seen, there have been reports of the occasional person who has had a second exposure and second infection to monkeypox. So what we do know is that because we have anecdotal reports of 1 or 2 cases amongst health workers, even for example, of a second infection, we know that protection from a single infection is not absolute. Probably there is immunity after the first exposure and infection, but it may not be for everyone, and it may not be, we don't know the duration of the immunity.
Thanks, Rosamond. We actually have a number of questions on transmission. I'm going to club them all. There are questions on airborne transmission. There are also questions on, does it transmit through lactation and breast milk? And what precautions to be taken?
Well, shall I start with the easier one, lactation and breast milk? Well, the answer is we don't really know. There have been so few cases reported. Now, infants have been infected, pregnant women have been infected. I'm talking about mostly the past cases that we were familiar with in the Central African Republic or Nigeria. And so what we do know, of course, is that an infant can contract the infection from their mother because of the close contact of breastfeeding, and a mother can contract the infection from an infant because of the close contact, skin-to-skin contact of breastfeeding. There is as yet not much information as to whether there's any virus in the milk. Remember, if the mother herself was already exposed in the past through natural exposure, then there may be some protection through breast milk. At the moment, the recommendation is to do what is best for the infant. Of course, that should always be the recommendation, which is, if it's possible, to isolate a mother who's infected separately from the child, or a child who's infected separately from the mother, then and provide interim alternate infant feeding, then that would be ideal. But we recognize that that may not always be possible, and that there may be circumstances, certainly in endemic countries, where what's best for the infant is to continue breastfeeding. So in that case, the mother can wear a mask during the breastfeeding, so that the mother is not, if the mother's infected, well, in both directions, whether the mother's infected or the child, the mask will protect both parties. So that is an area that, as Sylvie has mentioned, there will be a research and development seminar over 2 days this week to outline all the questions that are needed for this new event, and certainly breast milk will be one of them. When it comes to transmission through the air, which is obviously a very difficult and challenging area of work, we've all learned from COVID that terminology is critically important. We are discussing that extensively with infection prevention and control experts, infectious disease experts, clinicians. This is being discussed over the last 2 days. The third meeting is today to have these conversations around, what do we know and what do we not know? What we know is that there can be transmission from close contact because of lesions in the mouth. Droplet transmission is very clear. That is well described and has been known in the past. What we don't know is whether there is aerosol transmission. Clearly, if there's an aerosol generating procedure, such as bronchoscopy, that ideally this would be deferred. You would not be undertaking that kind of procedure for someone who has an active case of monkeypox. But if these procedures for the life of the person cannot be deferred, then clearly the health worker needs to take all the precautions that have been learned through the course of COVID-19. And then the final question is there actually aerosolized virus from talking and breathing? This is something we do not have the answer to. And we encourage those who are interested in this to raise the questions in the right fora for research and development, so that studies can be rapidly developed around these first few cases, so that answers can be learned sooner rather than later.
For that comprehensive response, and I hope that answers the questions, because there are many that are coming in. There's another very common question is, could monkeypox cause a global pandemic like COVID-19? I think there are lots of concerns around that.
Well, again, the answer is we don't know, but we don't think so. What we've known in the past is that this virus does not transmit so easily between persons. As I mentioned in the past, the R0 has always been less than 1. We do not have information that this is a very large DNA virus. It's one of the largest viruses known, and so its apparent existing properties are that it mutates much more slowly than, for example, RNA viruses. So there is not so much information right now on, we're just seeing the first few genomes being put up. We don't have a lot of information on what the genomes of the viruses being detected in this current multi-country outbreak are really telling us yet. That is already a discussion that is happening in circles of virologists working together and looking at these things. So at the moment, we are not concerned of a global pandemic. However, we are, and that word would need to be defined in the context of an orthopox virus. We are concerned that individuals may acquire this infection through high-risk exposure if they don't have the information they need to protect themselves. And we are concerned that because the global population is not immune to orthopox viruses since the end of smallpox eradication, that the virus may attempt to exploit a niche and spread more easily between people. But we don't have the answers to this question yet. Thanks.
Thanks, Rosamund. So with that question, we've come to the end of the hour. So I think it's time to wrap up. There are many, many, many more questions, but I'd like to refer everybody to our very comprehensive Q&A section of the website in the WHO website. And please go through that, as well as the monkeypox fact sheet, which gives you a lot of information, and it is updated. So many of your questions will be answered there. If you have any further questions, well, do write to us on the EPI-WIN link that you registered to us, but I think you will find most of your answers there. Thank you very much for participating. Any final words, Sylvie, before we wrap up?
No, just thanks to all of the people who participated, who asked a very important question. It helps us a lot also to prepare all the technical guidance and the Q&As and fact sheet, because what we would like is really answer your concern, your questions, and not just divulgate technical information abruptly. So your contribution, your participation, your question are really important for this dialogue. So thank you very much for making the time, and we hope to see you very soon for another update. Bye-bye.
Thank you very much for participating, and hope to hear from you soon. Bye. Bye. Thank you, Sylvie. Thank you, Rosamund, and thanks also to Judith for who's in the background, has been hosting this webinar, and to Tazara, our interpreter. Thank you.